Welcome to EASL Studio, your weekly hepatology broadcast news. In today's episode's tips, how far we can go, we will be discussing the limits, the clinical limits of tips. My name is Virginia Hernandez-Gea. I'm an interventional hepatologist working in Barcelona, and I have the pleasure to have as a faculty three renowned experts, two hepatologists, Professor Drihat Tripathi and Professor Dominique Tabou, and one interventional radiologist, Professor Thomas Kronke. So welcome everyone.
Welcome.
Okay.
Let's start discussing. So I would like to have your opinion, Dominique, in a case that I recently have. Is a child C12-point patient with alcohol-related liver disease, severe bleeding, that you put the patient on somatostatin, you do IBL, but you cannot control the bleeding. Patient has a creatinine of 3, is hemodynamically unstable, but you manage to put an esophageal stent. However, the patient is requiring high dose of noradrenaline, and you are like waiting for all the workup for infection because you think that the patient is infected. So do you go for salvage tips in this patient?
Well, hi, Virginia. Well, thank you very much for the clinical case. It's still a very frequent clinical case, and we still have that every week in our ICU, for example. So this patient has refractory bleeding, and despite all the treatments. The thing is that TIPS is working. It's not working as well as if it was put before, but salvage TIPS is working, and we are trying just to avoid to do futile salvage TIPS. And so we have several criteria, but of course it's always, in my opinion, a case-by-case discussion. So for example, in this patient, I would look at some indicators like, for example, a MEL score of 30 or over. There was one study showing that those patients do not do well. Lactates also more than 12, but probably we should also see the course of lactates, which was not studied in this study, and maybe very high ACLF 3B or 4 patients are really TIPS is not doing so well. However, I want to point out that this is always a case-by-case discussion, with the discussion, of course, of liver transplant behind or not. And it won't be the same if your patient is eligible or not. So it's really a case-by-case discussion. But yes, we can retain that those criteria could be futility criteria on one study for salvage tips.
So you said MEL, Dominique. However, I have the impression that most of the time when we evaluated the patient, we rely on the child PUG criteria. So when we are evaluating for futility, you prefer MEL? You think that child PUG still works? So what would be like the cutoff where you will start like being like very uncomfortable?
Yeah, I would be very uncomfortable for child C14 or 15. In those patients, I would be uncomfortable and really discuss, and we published some patients who had salvage tips and then had liver transplant and it was successful. So here I would really discuss the transplant together with the tips, because those patients probably won't do well after tips, child C14 or 15. And MEL 30 was in the study, the only study of Walter, which was published on futility criteria. But those are very severe patients, and the idea here is to discuss on a case-by-case basis.
Yeah, I think that this is the main idea, right? Patients will go to the ICU, and there are like many things that count into the equation. So let's move a little bit now to a different patient. Patient is a child C13 points. Now it's bleeding, but we can control the bleeding with endoscopy and putting the patient on somatostatin. However, we know that this is a very high risk criteria of rebleeding, and this patient could be a candidate for preemptive tips. So Drihat, I would like to know what is your opinion in this patient, and if you think that we should really go for preemptive tips, or what are the parameters that will prevent you prescribing preemptive tips in this patient?
Thanks, Virginia. And it's really important to differentiate the indication here. Where salvage tips is, as you discussed, somebody very, very sick, where you're getting control with a stent or a tamponade. So patients who are considered for a preemptive tips would not be a patient who has uncontrolled bleeding, and the benefits are significant, as we know from the recent individual patient data meta-analysis. And indeed, the futility criteria for salvage tips, I'm not sure you really can extrapolate to a preemptive tip situation, because I know Dominic and others have looked at that they try to discover if there is a specific criteria that can be used for futility and preemptive tips. And it's really difficult because the magnitude of benefit is significant, and the patients are those that are controlled. And what you really want to do is to prevent this treatment failure, which tips does so well. So it's really difficult to identify. In this particular case, with a Child-Pugh score of 13, I would think they could really benefit, provided there are no other major concerns for a TIPS. And things like even encephalopathy during an admission should not necessarily. We just had, for our trial, the REACT-AVB trial, we'd had exactly that same scenario. This patient had a acute episode of hepatic encephalopathy, but no previous episodes. So in the context of a bleed, that shouldn't necessarily discourage preemptive TIPS. So I think there are the precise futility criteria are not yet defined. And I think these patients should be really considered seriously for preemptive tips with the available data that we have.
Yeah, I think that this is a very important point, right? When we have a very, very sick patient, we cannot stop the bleeding. Then here is important to define futility. However, if you can control the bleeding, there are like many things that goes into the equation. And what you want to do is like really preventing another bleeding, a rebleeding or a failure that will put the patient in the in the first case. What about Diraj, what about ascites? So you have this child C 10 points, 10, 11 points, 75-year-old a patient that is referred to you has been following large volume paracentesis for the last year as a frequency of 2 times per week. So it's a little bit old, a little bit frail, a little bit sarcopenic, and the big problem is refractory ascites that started every month, but in the last 6 months is every 2 weeks.
So yeah, whenever I think have a patient in front of me with refractory ascites, I always think about particularly the transplant option. Now, 75 is pushing it for a liver transplant. I think most we don't obviously have an upper age limit, but it isn't somebody that we would immediately think about a transplant. Now, there's a clear distinction between refractory, which this patient clearly has, and a recurrent ascites. So as we are aware, the data by Christophe Bureau showed that in recurrent ascites, there is a clear benefit of TIPS, but in the refractory situation, the benefits are not really as strong and probably not there. And we have to think also, this is 75-year-old, and really frail. We have to consider the complications of TIPS as well, hepatic encephalopathy in particular, and also, somebody like this who's not a transplant candidate, we're thinking about a palliative pathway as well. So I think that, and so what we do certainly here is we do that in parallel to interventions, because some patients may not be suitable for a TIPS. And the other option that we have, especially in the refractory ascites situation, is a long-term abdominal drain. And we are running a clinical trial at the moment called Reduce True to look at this. And what's important here is the quality of life of the patient. That's what you want to optimize, especially in the absence of a clear transplant route.
I think that this is a controversial case, so I would like to really know Dominic's opinion in a patient like this. And also, what about timing? No, because I'm telling you that the patient has been like 1 year receiving large volume paracentesis. So Dominic, what's your view?
That's exactly the issue I wanted to address, Virginia. This should not happen anymore. To have patients with twice a month paracentesis and nobody thinks, well, we should maybe discuss tips. And maybe after that, if we contraindicate tips, we go for other options, as Diraj said. But here, you know, and I'm always fighting to tell the student, well, when you have patients coming and coming again with paracentesis, there must be a discussion, because really this cannot happen. So that was my first thing I wanted to tell you. Second thing is that for me, I agree with Dheeraj, 75, you cannot go for transplant after. So you have to know what you're doing, because in my opinion, as you say, we always discuss in our unit tips and transplant together, but some patients are not eligible for transplant. It doesn't mean they are not eligible for tips, but we just have to know it before and know you won't have anything after if something fails. So in a particular patient like that, 75 is not a limit for me, and I don't contraindicate tips for this kind of patients. And there is a study showing that age, there is no limit of age. But the thing is that frailty is also a big issue, and being old is being more frail. That's the issue. So I try to consider and to discuss with the patient. And several months ago, I had exactly the same patient. We discussed with him and his wife. He couldn't stand anymore the paracentesis. He didn't want something else. And we went for this with the discussion of the risk of hepatic encephalopathy and the discussion of everything. And altogether, we discussed to go for it. So for me, it's not a strict contraindication, but a discussion again on a case-by-case basis.
So would you be like more worried, Dominique, in hepatic encephalopathy happening in this patient versus the other patient with bleeding?
Well, because he's old, you know, you can have also other confounding factors, and probably the brain is primed in those patients, and probably they do more often hepatic encephalopathy because they have an old brain. Let's say it into bracket like that. So I would be more concerned, but I know that I have treatments to prevent hepatic encephalopathy before elective tips. And I know that after that, if there is a big encephalopathy, I can still revise the tips, and we have many other options to treat hepatic encephalopathy. So yes, I'm worried, but not so much. I'm more worried in patients with renal failure, very chronic renal failure. You know, those patients go for HE quite easily. This is for ascites. And as you know, for preemptive tips and bleeding, I'm not at all worried by hepatic encephalopathy, but that's another topic.
Yep. So Thomas, how important is from the technical point of view when you have the patient in the room? So do you care about the indication? So do you do things differently if you have a patient with a bleeding versus a patient with ascites?
Virginia, yes, of course, we do it differently, and not from the technical approach, meaning access or something like that, but of course, for example, in placing the stent and then deciding how should the diameter look like. Now that we are in the area of constrained stents that can be under or over dilated, so you have some options to adjust stent diameter. And of course, in a situation with active bleeding or in the salvage tips, decompression is the most important thing you can do at that moment. While in a patient like you discussed, just the last one you discussed, you might consider to have tips which is smaller and have it under dilated, and see how it works, and see if that you can gradually come back maybe and see, okay, is it functioning in the way we think it is functioning, and we can dilate it to a larger dimension later on. So there is some thought of what kind of patient is actually receiving that tips.
Yeah, like personalizing the treatment. Yes, I really like that, because ascites is not a life-threatening condition in the short period of time. So we have time to adjust the diameter. But what about the hepatology? So how you explain the patient that they will go for tips because they are undergoing paracentesis, that maybe this tips is going to be under dilate, and they will need paracentesis after the tips, probably for a short period of time. So how is your approach, Dominique? How do you explain the patient this situation that is not going to be a treatment that will right away get rid of the ascites?
Well, I think that's easy to explain because you say the truth. So you have to explain how it works, and that's always how I do. And saying, well, we are trying to have a smaller diameter than we could because of the risk of other complications. But well, please beware, this can take a little time, and don't be desperate if you go back for paracentesis. And in my clinical practice, I don't know for you, Dheeraj, but I don't have any issue with this particular point.
So Dheeraj, how is your approach, and when would you decide that this tips is not really working, and then you will ask Thomas to further dilate these tips?
So I generally inform patients that this is not an immediate fix, because it's about managing expectations. So patients and the family, oh, I just want to get rid of this fluid. Are you going to do the tips? I'll be fine next week. That's not the way it works. I usually say wait a month, 2 months, and then you kind of see at that stage whether, and you look at how many paracentesis they require. So if they're requiring paracentesis significantly beyond a couple of months, I would think then this requires further calibration, and obviously if they're still okay otherwise in terms of hepatic encephalopathy, because obviously in the absence of etiological cure, the disease is going to progress. So I always do manage expectations and inform them at the time of counseling for tips that this is not going to work immediately, and you might need further revisions.
So how often, Rihad, so imagine that you are referring this patient for tips, and you also see big portosystemic shunts. So how often would you discuss with the radiologist, like, well, maybe we can do tips, and what about embolizing these shunts that maybe are also contributing or can increase the risk after placing the tips? So what would be your clinical approach? And then I would like to have also Thomas' approach to shunts in this patient.
Yeah, I mean, this is again a fairly case by case basis, and I would also look at the indication for tips. So if it's in the bleeding context, then often my radiology colleagues, if they're particularly if it was gastric varices, even with a reduction in the pressure, they would definitely embolize large varices in the bleeding context. But in the ascites context, I think it depends on the size as well, how big the shunt appears, and also the portal pressure reduction. So some may not consider embolizing if there was a good reduction in the portal pressure, but if the size of the shunt is large, I think the 8 millimeter cutoff is there, then you may wish to consider embolization. But it's a discussion that I have with our radiology IR colleagues and on a case-by-case basis.
Thank you. Thomas, what is your approach?
I'm completely in line with with what had been said. So yes, indeed, I think most interventional radiologists in the bleeding situation would definitely go for embolization of varices, etc., of shunts in this way. But like has been said before, if I see a sufficient reduction in the pressure, and of course pressure measurements are essential, and sometimes I would not say neglected, but they are an adjunct, which some people think are, wow, do we really need this? But it's important to justify in which direction you go. And of course, the imaging also shows you what is the filling. Do you have an imaging which shows that the flow into the varices or in the shunt is less? Well, and you have a good reduction in the pressure. There's no definite need to do this, but that's, as I said, also a discussion always on a case-by-case basis.
Yeah. What about you, Dominique? What's your approach to embolizing or not collaterals?
I'm completely in line with this, and I always discuss with the interventional radiologist, and we generally agree. What I wanted to point out is that probably the fact that there is still a feeling of the collateral after the tips is a good idea then to go for it, even if the literature is scarce, as you said, Thomas. I wanted to point out also that embolization is very useful in case of refractory encephalopathy after tips. especially if you have large shunts, and this works pretty well. So this is outside your question, Virginia, but I wanted to point out that because
No, I think that this is also like something important. So even if we made the decision, and sometimes because we do not have very good predictors of hepatic encephalopathy, then the patient is with refractory hepatic encephalopathy after the tips. Sometimes you cannot even like really predict that, but happens. So what's your approach, or how would be your discussion with the interventional radiologist? Would you close, ray caliber, looking for shunts? What would be your, how would you start the discussion?
Well, starting the discussion, I would start to treat my patients for hepatic encephalopathy because we have medical therapies. So that's the first thing. And after, I would have a look with a cartography of what's happening inside. And this is really a discussion with the interventional radiologist, and seeing also the effect of the tips, if we are happy with the effect of the tips on portal hypertension. But if there is over shunting and hepatic encephalopathy and low pressures, I would discuss with the interventional radiologist. And as I said, if there is one shunt which is very large, I would go very easily for the embolization after medical therapy if there is still chronic HE. But again, this is really a discussion with the radiologist and what is feasible. I don't know if you agree, Thomas, on that, but discussion with the clinicians about that.
No, completely. And as I said before, just looking at the image is not sufficient. So we need to have the decision in an interdisciplinary format and say, well, how can we improve the situation? Have we done everything else? Can we exclude that there are other things which contribute to the HE, and then decide? And then, like you said.
Yeah, Direk, do you want to add anything?
Just a quick question, Thomas. I mean, when you thinking about embolization, there was shunts. Would you do it if you went down and saw the shunt? Would you do it in terms of in relation to the TIPS procedure itself? Would you do the TIPS first and then embolize through that, or would you embolize the first any shunts?
Well, the one approach could be embolize the varices or the shunts first. This might be prevent that any misplacement or coils or anything can go through the open tips, although this is very rare. So I don't think we actually do first the tips and then look at the flow, as I said, and look at the decompression, and then decide, and then go for the embolization. And usually it's a mixture of either coils or coils and glue, which works perfect and is easy to navigate, and that's how we do it.
Okay, so what about like leaving hepatic encephalopathy? Another thing that worries a lot of medical doctors is the impact in cardiopulmonary complications, right? So Thomas, what's your approach when you are like doing the procedure? Do you measure routinely cardiopulmonary pressure, and when would you like really contraindicate the tips? So when is like clear for you that you wouldn't go with the procedure?
Well, of course, we do an echo beforehand, but we just learned the hard way that this is not sufficient. So we just recently had a case where we had all things in place and did the tips, and were surprised with the cardiac decompensation that the patient had. And we are now looking, like many in pro-BNP, and look if we can establish not a cutoff which is not established, but to have it as an adjunct measure how much stress is on the heart. So these two things are essential for me as well, besides pressure measurement. We do not do routinely pulmonary artery pressure beforehand or something like this. So the echo and the pro-BNP is important for us for decision making.
Okay, so what is the parameters that Direct you rely most before like taking the decision of going for TIP? So you evaluate, how do you evaluate cardiopulmonary risk?
So we have published in the past a paper on the use of echocardiogram. This is just standard transthoracic echocardiograms, particularly looking at diastolic function, and didn't find a clear link between diastolic dysfunction and cardiac decompensation afterwards. However, based on the data from Christophe and the Toulouse group, we do definitely check NT-proBNP on certainly in the elective setting. In the acute setting, it's probably not maybe as informative, but we do check it anyway. And clearly, it can be a marker of cardiac dysfunction post TIPS, but also a marker of pulmonary hypertension. And the thing that we really do look for is anything to suggest pulmonary hypertension. And most guidelines, would advise a mean pulmonary pressure over 45 as a millimeters of mercury as an absolute contraindication. So, and again, kind of learned the hard way. I remember as a trainee, we didn't do echoes, just did an ECG, that was it. And a patient developed a refractory right heart failure. I'm sure colleagues may have seen that, and that's almost impossible to treat when there's, especially elderly patient. We do a standard echocardiogram, and in those patients where the NT-proBNP is elevated, or if there's a clinical concern, don't forget the clinical examination, ECG, and so on. So we must use our clinical acumen also to decide on the need for additional investigations. And I'm seeing more and more colleagues doing an echocardiogram anyway, especially in the elective setting, in the patients being worked up for ascites. And we would, again, the interpretation is important. So we have a very friendly cardiologists in our team who have a lot of experience and will guide us with regards to the interpretation, because one of the things that we have to be careful is doing an echocardiogram in a subject who's got fluid overload, lots of ascites. That's not going to be a reliable echocardiogram. We often repeat when the less fluid overload. And we also use invasive measurements in selected patients guided by cardiologists. The right heart catheter can be really, really helpful.
So, Dominique, now that we have more and more MASLD patients that they have like high cardiovascular risk, and sometimes even cardiac diseases, what's your approach to this setting of patients, and how do you evaluate the heart?
The heart. Well, I'm completely in line with Dheeraj. The thing is that those patients also can have systolic dysfunction, systolic and diastolic dysfunctions. They can have also valvulopathy, and they can have, of course, pulmonary hypertension. So I'm doing basically the same. I would like to stress that the clinical examination, as Dheeraj said, is very important, looking for edema, etc., because some things are really obvious like that, and you can have a normal echocardiogram depending on the feeling, but you can have also signs, clinical signs. Of course, BNP, NT-proBNP, also ECG, and of course, echocardiography. And then we don't measure right atrial pressures all the time. We discuss if we have a doubt, we must measure them, of course, because we consider, as you, that pulmonary hypertension is an absolute contraindication for
TIPS. That's a really dramatic situation, and this could definitely stop me of going forward with the TIPS, and then I will call the pulmonologist and we will try to treat the patient, and let's wait a little bit. So Dominique, you before said something about how concerned you are with the kidney disease, and now that we have like more and more of these patients with comorbidities and cardiovascular risk and diabetes and chronic kidney disease, so how do you manage? When is a no-go in a patient with severe chronic kidney disease?
Well, I don't have really no-goes except HRS1, HRS-AKI, where I think that right now there is no indication and maybe a contraindication for TIPS. So I'm really cautious on those patients. And for them, you have also other projects and generally LT. So, and I know that there is a study ongoing, but right now we don't have evidence to do that. But for HRS2, HRS-NAKI, I don't have any strict contraindication. Just the thing, as I said, that those patients will develop more encephalopathy, and more because probably they have MASH and so diabetes, which is also a predictive factor of hepatic encephalopathy. So being very careful, trying to avoid all other neurological factors and risk factors, and also treat before with these treatments. And so we give in France, after the French study, rifaximin 15 days before elective tip for that. So, but I don't have for renal failure real contraindication except HRS-IKA. So that's it. And after that, again, it's a case-by-case basis discussion,
So Thomas, how important is now portal vein carcinoma? So when you have a patient with refractory complications of portal hypertension that has a clear indication for TIPS, and then you see big carcinoma. So it's like something from the past, and now we do not care and we can recanalize and go for TIPS, or is it still something that we really care about?
No, I personally would care about it. So to be honest, of course, there are now some new technical tricks, and interventional radiologists are very keen on trying to show that it works in different scenarios. But we must admit that the situation itself is not similar among or between patients, and it's very individual. I think you cannot say, well, it's a thing from the past. We are less hesitant to go for it, to be honest. But I think I see a lot of progress in very experienced centers, but I would not recommend to say, well, it's an issue from the past. It's technically challenging and very individual.
Yes, a technical challenge for sure, and maybe center of expertise here, they also play a role. So we are like running out of time, but before concluding, I have the feeling that the indication of TIPS, or the number of times that our surgeons colleagues ask us for TIPS pre-surgery is increasing, and I would like to have like also the opinion of the panel is like, should we really go for TIPS before surgery in our patients with portal hypertension?
Okay, I can make a start. So yeah, I mean, we've looked at this in our series. Although this was just a relatively small numbers, and just the cohort of patients that had the TIPS for surgery. So we're talking about patients who've had a TIPS procedure within usually most of the studies between 3 and 6 months of the surgery, and indications vary from the traditional classic indications, ascites, or actually specifically for the purposes of preoperative optimization. And what and prior to the study that you're aware of, Virginia, from Barcelona group looking at pressures, we used to just select patients who had predominantly compensated disease and features of portal hypertension. But again, there's recent data to suggest that patients that actually have some degree of decompensation do actually better with improved survival. So we're broadening our indications, but the thing that we're really keen on now is measuring the pressures. And as you're aware, Virginia, we're part of the multi-center study looking at the role of pressure, HVPG, prior to making a decision on TIPS. So we do definitely offer it. And the data is rather heterogeneous and sometimes conflicting. Some would say that there is a benefit, and others would say there isn't a benefit. And you have to look at the patient selection in all the studies. But we would certainly consider it in those patients where there is high pressure, and broadening the indications to include those patients that have maybe a degree of decompensation. And always think also in terms of the type of surgery, high risk or low risk surgery. That's also important to consider.
Thomas, anything that you would add?
Well, I'm just wondering, are we talking about patients who will receive curative surgery afterwards, or are we talking about patients where we think of optimizing the situation before we treat, for example, HCC, which I think is the situation I see the most. And yes, we are we are doing this more to optimize the function, and we see some good results, and then treat the HEC if it's anatomically possible, etc.
So I would really like to have Dominic opinion on this. So putting a tips before treating HCC. I would really like, I know that we're running out of time, but I cannot.
Thank you. Well, I'm not against it. I think the absolute contraindication of tips in patients with HEC is when you go, and almost absolute, I would say, is when you go through the tumor. And sometimes you say you do it because of refractory bleeding, but you have to choose how your patient is gonna end. That's not easy. But otherwise, I'm really not against it, provided you don't cross the trajectory of the tumor. And I think this can be very helpful to put tips in patients with HCC in order to download them also and to be able to offer curative treatments. So for the specific topic of local resection, for example, well, we don't have enough data in the literature, as you know, and some trials are running, but I would say that the surgeons will consider then a high HCPG more than 12 could be a contraindication, and they will discuss with us, and they will prompt the tips, which is rather new, and that's what we are doing because of the risk of the surgery. So I'm really often in favor of it, and well, really, yes.
Well, it's a reality that our patient population is changing, and now these patients, they live longer, and and we are broadening indications. So I'm sorry, but I have to close this episode. Thank you very much for all the input. And next week, join us for the final episode of this season, delivered as a master regulator of aging, health, and longevity. And remember to become a member and to join EASL family. See you next Wednesday. Bye-bye.
Bye-bye. Thank you.